Hello. My name is Virginia Bode, and this is videobeaux. This is the zapruder program mode. This applies a zapruder film-like effect to the source video. You know, the film of that tragedy from back in the day. I hope you enjoy. Try it out today.
Good morning everybody and welcome to Health Talk. I am your host Dr. Neeru Prasad with my background in pediatrics and emergency medicine affiliated with Henry Ford Health System, St. Joe, Oakland and Beaumont. The theme of our Health Talk today is prevention and screening of colorectal cancer. Joining us today as our guest speaker is our surgeon, Dr. Farooq Tutla from St. Joe, Oakland, and he's going to highlight our viewers about the incidence, prevention, screening for colorectal cancer. Good morning, Dr. Tutla, and welcome to my show.
Good morning. Thank you.
And I'm so happy that you were able to come today because this is a colorectal screening month. March is it, and today was the last day. So before we get started, can you give your introduction to our viewers, please?
Okay, colorectal cancer is the second and third most cancer in both men and women.
Okay.
And it is the second most common cause of death from cancers. So it's very important that we have some kind of prevention done so that we reduce the rate of colorectal cancer.
Exactly, yeah. So I know you, being a surgeon, you see a lot of incidents of it.
Absolutely.
Yeah. How many surgeries do you end up every week or every month?
Well, on the average, I do about 3 or 4 colon cancer surgeries every month.
So that's quite a bit, though.
Quite a bit, right?
Yeah. During the number of years of your practice, are you noticing that incidences get more and more, or is it less?
In fact, after the insurance started paying for screening for colorectal cancer, there is a slight decrease in incidence of colon cancer.
So it's good for our viewers to know that with the proper screening at the proper time, the incidence gets less.
Yes, absolutely.
So that's good, yeah. So so before we go to prevention and screening, can we touch the risk factors and the age group?
Okay. The most common age that the population gets colorectal cancer is over 60 and more common in the 70s.
60s and 70s.
But recently we've seen an uptick in diagnosis in younger people below 50.
Okay.
So there is an increase in colon cancer in the younger age.
Yeah.
And this, I think, has got to do with a lot with lifestyle.
Yeah. So can you please elaborate on what are the risk factors that young age group are coming to you?
Okay. We found that colorectal cancer is more common in people that have a high intake of red meat.
Okay.
People who are smokers and people who are obese.
Okay.
And also there's a slightly higher incidence in people that abuse alcohol.
Okay. So those are for the viewers to know, those are the 4 major factors.
Those are the lifestyle
factors. Obesity, drinking alcohol, smoking.
And eating of red meat.
Red meat.
Right.
That is very scary because a lot of people love eating a steak.
Yeah, but the problem with red meat is the fat in the red meat.
Fat.
And the theory of why red meat is not good, the fat is broken down by the bile acids, and if it stays in contact with the colon for a long time, it becomes carcinogenic, means it promotes abnormal cell growth in the colon. And that's why they say either don't eat red meat or decrease the amount of red meat you eat.
Right, yeah. Decrease, add more white meat.
Yes,
like
more
chicken,
white meat.
fish, and those kinds of
Chicken, fish, and turkey.
Right. So those are the risk factors. And Dr. Tutla, what are the symptoms that they will be coming to you? What are the symptoms suggestive that they will make? Because as a primary care physician, working at the emergency room or family practice, I just go through the symptoms. I do the basic test while I'm at the urgent care. And then if I see that there is any suspicion, then I refer them to you. So what are the major symptoms that could be a scary factor that I will send the patient to your office?
When early in the disease, there aren't any symptoms.
Right, yeah.
So that's why screening becomes very important.
Right.
But if the tumor grows to a certain size, then they can present with rectal bleeding.
Right. Yeah, that is a very risky factor.
Changing bowel habits. Okay. Weight loss if it's very advanced, or they can get constipation or diarrhea.
Right.
Those are the common things. Abdominal pain occurs if it's late. If it causes obstruction, then you can get cramping abdominal pain.
Vomiting.
And the other thing is anemia, of course.
Yeah.
Patients feeling fatigued and tired. You got to make sure that they don't have cancer, especially on the right side of the colon.
So then they will go, I will send them to your office, doctor, and then when they come to your office, then what are the basic tests that you will be doing before you get started with the surgical aspect?
Well, the most common procedure that we do is being a specialist.
Yeah.
They send me for tests to see why they're having the symptoms.
Right, yeah.
And what I do is I make sure I take a good history, do a physical exam, do a rectal exam, and then schedule them for a colonoscopy.
Okay.
Because that's the most sure way of detecting colon cancer or colon polyps.
Right, yeah. So for the colonoscopy, for the possible bleeding and to detect the polyp, right?
Yes.
Because in the emergency room we have those strips check for the occult blood. I don't find that too diagnostic though.
Okay,
the one that we have at the emergency.
The hemoccult test, the old one, they're not very reliable.
No, it's not.
Because the patients have to be fasting, they have to be off medication like aspirin or Motrin or Aleve. That will give you a positive test. Hemorrhoids will give you a positive test. But they have newer tests now to test the stools.
Okay.
One is Cologuard test, which actually measures the DNA of blood in the stools. Okay? That's a much more accurate test
than the previous.
Yeah, and then they have the fecal immunochemical test, where they detect globulin in the stools. And if those are positive, then you've got to have a colonoscopy done. And most of these tests are done by family physicians in their offices.
Okay.
Because in my case, being a specialist, I don't do it. I usually
you don't do it. So as a family practitioner, we will do the test. If it is positive, we send it to your office.
Right, absolutely.
Yeah, and then you will schedule them for colonoscopy. Okay. So during the process of colonoscopy, sometimes the patients are very scared, I'm going to have this procedure. What would you advise for people like us who are going to you to get a colonoscopy?
The colonoscopies are extremely safe.
Okay.
Firstly, the procedure is done under sedation, and we usually get an anesthesiologist or anesthetist to give them sedation, so they're more asleep while we do the procedure.
Okay.
The worst part of the procedure is the preparation the day before.
Yeah.
I mean, that's what most of the complaints are.
Yeah.
So they don't like to drink all the fluid and, have diarrhea. They take laxatives, so they get cleaned out. The bowel has to be absolutely clean.
Yeah, because you can see what is there.
Yeah, otherwise you miss small lesions, small tumors, or small polyps. You miss them.
Yeah.
So that's why your bowel has to be absolutely clean. So people don't like that. They don't like drinking a lot of the fluid. Some people get nauseated.
Yeah.
So we try and reassure them. But there are newer prep solutions now that you don't have to drink so much of water.
Which is good then.
Yes, it is good.
Yeah.
The easiest part is the colonoscopy. The hardest part is the preparation.
For you. Because as a surgeon, for you, it doesn't take too long, right?
Well, it takes, on the average, it takes about 15 minutes, 20 minutes
15
to do the colonoscopy.
Okay.
And because we use propofol now, which is a very short-acting hypnotic, so as soon as the procedure is done, they wake up within 5 minutes, and they are alert, and they feel very good afterwards.
Yeah. So they will go to. I will go to your office. We will have all those preparations done, which is the scary part. But actual procedure takes, like, I would say, 15 to 30
approximately. That's the average.
Now, this is, I believe, it is an outpatient, right?
Yes, it is outpatient.
Okay. Are the patients discharged the same day, couple of hours?
Usually within an hour after the procedure is completed, they go home.
Okay. So what kind of advice and precautions as a patient I should be following after I go home?
Okay. Most patients feel somewhat tired after the procedure. They're not allowed to drive afterwards. They have to bring somebody with them so they can drive them home. I usually advise them that everything went well, there's no issues. They can go home and eat a regular diet and rest up for the rest of the day. The next day they're back to normal.
Back to normal. Good, yes. So now when you do the colonoscopy, suppose they have everything is normal, mucosa is normal, then you don't worry, right?
Right.
I don't worry.
Right.
But what if you see polyps or anything?
Usually polyps are usually taken out at the time of the colonoscopy.
Okay.
And usually they're very small. We usually biopsy them and burn them. Take a piece of tissue.
Cauterize them.
And then cauterize it. If there are larger polyps that have a stalk, then we put a wire snare around it, and we excise it, and then collect the specimen and send it to the pathologist.
Okay. So that's the whole thing, is that if there is a visible polyp, then excise or cauterization, right?
Absolutely.
So if there's an extensive lesion involving the whole colon, then it's a different.
That's a different issue.
Different issue, right? Yeah.
And in a situation like that, if you can take it out piecemeal, it's fine. Or you can do it on 2 or 3 settings, taking it out piecemeal. If you find that you cannot do it, there's a danger of perforating the colon, which is very possible with large flat polyps.
Yeah.
Then the best thing to do is to do surgery and take that portion of the bowel out.
Right. Yeah. That's true though, because recently I have a very close patient I have been following, and just by the resection couldn't do the colonoscopy, so they did the resection. It turned out malignant.
Right. Absolutely. Yeah. That's always the danger of the large lesion and a flat lesion.
Right.
They have some cancer cells in them.
Cancer cells in them.
Right.
Yeah. But then after that, the therapy just changes altogether, right? If it is a cancer cell.
Well, once we take out the bowel specimen where the cancer is, we send that to the pathologist, and then we have it staged. And the staging involves not just only looking at the bowel specimen, we have to look at the lymph nodes, how many lymph nodes are there, is there any involved. They have to have a CT of the abdomen and the pelvis to make sure there's no spread into the liver, and a chest X-ray to make sure there's nothing there.
Nothing there, yeah. Do you see more incidents, Dr. Dutla, in male or female, or is
They're about equal. About equal, yeah.
Because I was thinking that with the women it should be less hormone protected, no?
No, hormone doesn't protect
Nothing
you.
to, nothing
No, doesn't
to.
protect you. No.
So equal incidence in male and female.
Right.
Yeah. And yeah, like you said, usually the older age, but recently incidence has been more in the younger age group.
We're seeing more and more younger people getting colon cancer.
Right, yeah. So treatment is basically a resection of the colon or the polyp,
Yes.
whatever, followed by further investigation, CT scan and all those. Yeah. So what else would you like to elaborate?
Well, I
Our
think,
viewers, what else would you like to tell us?
the most important thing is screening.
Right,
there is-
prevention and screening.
The standards for screening right now is any male or female over 50 years of age
Okay.
should have a colonoscopy at least once every 10 years.
Yeah.
If they are average risk, means that they don't have any family history of cancer, first or second degree relatives, and they don't have a history of polyps, or they don't have a history of colitis, osteocolitis, or Crohn's disease. Those are the things that you have to do to prevent it. If they have a history of colon cancer, or if they have a family history of colon cancer, it depends when the first degree relative had the colon cancer, when it was diagnosed. So you have to do a colonoscopy on the relatives at least 10 years before the diagnosis.
Is that so?
Yes.
So 10 years before someone does all the
Right.
genetic, has there been any link with the genes?
There is a link. There is a link with genes. They have found several genes that are abnormal with what's called the suppressor gene. They
Yeah,
what's
the
called-
T cells, abnormal
yeah,
cells in the
right. The suppressor genes
T cells.
sort of suppresses tumor. There's always cells that are being formed that are abnormal.
Right.
The suppressor genes usually kills them, but
Right.
somehow the suppressor genes doesn't work,
Mm.
and that allows the cancer cells to proliferate.
Right, yeah.
These are called oncogenes that allow the abnormal cells to proliferate.
So for our viewers to know that some of the kind of colon cancer could be genetic
Yes.
linked, so the other family members, they should be investigated.
They should be investigated. Right. They should have some kind of chromosomal analysis.
Right, yeah. So basically it is, with the chromosomes you can detect.
Right.
Yeah, see, nowadays there's so much research work going on
Absolutely.
with the genetic link with everything,
Yes. Right.
a lot of research. Before, these things were not available.
The analysis were not available. Now they're available because there is a syndrome called the Lynch syndrome, which happens in families.
Yeah, the Pierce-Ziegler syndrome.
Yeah, well, that's
Familial polyposis.
Right.
Because I did my residency at Children's Hospital.
Right.
We used to see so many kids with this syndrome.
Right. Yeah, now they found that kids with Pierce-Ziegler syndrome, they also have risk of getting colon cancer.
Oh, okay.
All right. And the important thing I was stating was the Lynch syndrome, which is more and more diagnosed in
Lynch
younger
syndrome.
people. And they usually have colon cancer more on the right side of the colon than left side.
Is
And
there
they
any
usually
particular reason why it is more on right side, not left?
Well, that's the syndrome. I'm not sure why it does more on the right
Mesentery,
side.
maybe because of the appendix and the mesentery.
I don't think that's related though.
Okay.
But they occur in younger people, and the cancers occur any age after 30, more common in the 40s.
Okay.
And if that is diagnosed, their siblings should also be tested for the Lynch syndrome.
Right, yeah. Yeah, because the siblings should be also screened, tested, So that's amazing, isn't it, that all these syndromes. And there's one syndrome where you have a lot of skin manifestation. Often I'm forgetting the name. It's you have more dark spots all over your body, and So many syndromes are there.
There are a lot of syndromes. Right?
Yeah. So it's best thing just to have a prevention and screening. That plays the major role.
That's help in decreasing the incidence of colon cancer.
Right.
And if you have cancer, if it's detected early, it's more curable.
Right.
If
Yeah.
it's late detected, then the cure rate really goes down.
Yeah.
So that's a reason why people should get screened at as soon as they hit 50.
They should, yes, I thought it was every yearly, every 10 years.
If it's not, as the average dress, they don't have any family history, it's every 10 years. If they have a family history, then do it every 5 years.
Every 5 years, yeah. And hopefully, with all this rising cost with the health insurance, hopefully the medical insurance covers all those.
Medical insurance covers screening,
Screening.
is zero out-of-pocket expenses.
Good, yeah.
Okay, the only time that the insurance has to pay extra is if there's a polyp, we take out a polyp. If it's a screening colonoscopy, it's completely negative. The patients don't have to pay anything.
Right.
So it's zero out-of-pocket.
Which is good, that was a good Obamacare or whatever.
Whatever.
Whatever, we don't want to touch that part, but just so that we know that all those screening tests are covered by the insurance.
Oh, they're definitely covered.
Right, yeah. So that's good. So, as a last minute closing advice, what would you?
My closing advice is that if you have any family members that have had polyps, colon cancer, make sure you get screened. As soon as you hit 50, make sure you get screened.
You have,
either go to your family physician. There are other methods of screening also, like we've talked about, testing the stools for the blood. And some people suggest that you can do a flexible sigmoidoscopy every 5 years with a barium enema. And the best thing, as far as I know, is doing a colonoscopy. Then you can look at the whole colon. And there are newer scopes that have come out now, because sometimes polyps hide behind folds. So there is an instrument that we can flatten the folds out. So the pickup rate of polyps are much higher. If you take the polyps out, the chance of you getting colon cancer is much less. So the most important thing about colorectal cancer is prevention. And of course, the other thing I would advise the audience is that cut back on your red meat. Stop smoking. Don't abuse alcohol. Exercise, very important.
Cut off, and maintain the weight.
Right, maintain the weight.
So thank you very much, Dr. Tutlar, for coming on my show today. I like to thank our producer, our camera crews for helping me prepare this show, and thanks to Dr. Farooq Tutla, who is a colorectal surgeon with St. Joe, Oakland. Until I see all of you again, have a very safe, wonderful spring and summer. Thank you.
Thank you.